Most aftercare still defaults on to chlorhexidine. Bone building cells hate it. Start with biology. Warm saline first. Antiseptics only when risk demands. I'll show you the evidence and the exact steps. Early healing is fragile, as we know. Platelet clot, neutrophils, fibroblasts, endothelial cells, and then osteoblasts. Our rinse choice can help them or harm them. The goal is clean without cytotoxicity. Baseline is always isotonic saline, antiseptics only used by risk. What the data shows in brief: chlorhexidine controls plaque. It also shows dose-dependent toxicity to fibroblasts and osteoblasts in vitro. Povidone-iodine kills broadly, but longer or higher exposure harms whole cells. CPC and essential oil rinses reduce plaque in healthy mouths, yet they're not friendly to the early wound cells. Hydrogen peroxide drives oxidative stress. In clinical trials after periodontal or peri-implant therapy, saline delivers similar inflammation control to chlorhexidine when mechanical debridement is done. That matters. We need biology preserved. A simple protocol that you can use is the following. Step 1, for the first 24 to 48 hours, no vigorous rinsing. I would only use warm, low lukewarm saline. Hold and let it fall out. Do not swish over grafts or membrane. Step 2, after the first 1 or 2 days and for about 5 to 7 days, for low risk cases with small flaps, good hygiene and no infection, I would use lukewarm warm saline 3 to 4 times a day, 10 to 15 ml per time. Step 3, in higher risk cases where we have poor hygiene, immediate implants, wider flaps or GBR, you may consider adding a short alcohol-free chlorhexidine 0.12% course, 10 to 15 ml, 30 to 60 seconds every time, twice a daily maximum. Stop at 7 days. Never irrigate bone or membranes with antiseptics. And step 4, after the first week, transition to mechanical plaque control to the operated area. So basically brushing, and keep saline washes as needed. Escalate only if signs of inflammation persist. Now, how do we prepare that patient saline? Very simple. 1 to 1.5 level teaspoon table salt in 1 liter of boiled then cooled water. Use lukewarm, warm 10 to 15 ml per rinse. You hold, you let it fall out, and avoid forceful swishing. What to avoid in the first week after the surgery? We should avoid alcohol mouthwashes. Avoid CPC and essential oil rinses over the wound. Skip hydrogen peroxide. No water flossers across grafts or membranes, or in cases where we do full arch or zygomatic implants. And we always have to remember that biology comes first. Do we have any red flags where we need to review the patients as soon as? Of course, we have to review if there's persistent bleeding after the first day post-surgery, as with every surgery. If there is pain or swelling increase after day 3. If there's fever with foul taste, and if a membrane is exposed after GBR. You need to see those patients early. Chairside preoperative mouthwashes, what do we use? I personally like preoperative decontamination, and I ask the patients to use 30 to 60 second rinse of chlorhexidine 0.12%. Intraoperative irrigation stays sterile saline only, nothing else. Never bathe bone or membranes in antiseptics. So you should always remember, clean is necessary, cytotoxic is not. Saline first for most, almost all patients basically. Antiseptics only when risk demands, for short windows, never over grafts with force. Protect the cells that rebuild the site. Please find the relevant literature in the description below, as well as the recipe for saltwater normal saline preparation. Don't miss my next video on sutures, knots, and inflammation. Please comment with your current protocol and why, and please like and subscribe. Thank you.